Let me tell you about a Tuesday afternoon that changed the way I think about medicine forever. A woman, I'll call her Barbara, 72 years old, sharp as a tack, completely independent, walked into a hospital for what her surgeon called a routine procedure, a knee replacement. Her daughter told me, Mom was nervous, but the doctor made it sound so simple. He said she'd be back on her feet in 6 weeks. Barbara never made it back on her feet. Not because the surgery failed technically. The surgeon did exactly what he was trained to do, but Barbara developed a pulmonary embolism on day 3 of recovery, then hospital-acquired pneumonia on day 7, and by day 19, her kidneys were in distress from the cascade of medications used to treat everything else. She spent 4 months in a rehabilitation facility, came home to a recliner, never walked her dog again. The surgery was a success. The patient was not. That distinction, that gap between a technically successful operation and a genuinely good outcome is what nobody prepares you for. And if you're over 50, that gap is the most important thing you will hear today. My name is Dr. Raymond Osei-Bonsu. I'm a geriatric medicine specialist with 18 years working alongside surgical teams in major academic hospitals. And I want to be very honest with you right now. I'm not here to tell you surgery is bad. I've seen surgery restore people's lives in ways that still move me. What I am here to tell you is that 5 specific surgeries carry risks that are being dramatically underexplained to patients over 50 and sometimes oversold to people whose bodies simply are not ready for them. Stay with me through all 5 because number 3 is the one that surprises people the most, even other doctors. And the 4 questions I'm going to give you at the end of this video might be the most important sentences you write down all year. Before we get into the 5 surgeries, I need to give you a piece of knowledge that will reframe everything you've heard from a surgeon's office. When you're 35, your body has what physicians call physiological reserve. Think of it like a full tank of gas. Your organs, heart, kidneys, liver, lungs, they're running well below their maximum capacity most of the time. So when surgery hits the system hard, your body has room to compensate. It can rev up. By the time you're 65, that reserve has quietly been shrinking for years. Not because you've done anything wrong, it's biology. The tank still works, but it's no longer full. By 75, studies show that nearly 1 in 3 adults has what medicine calls functional frailty, meaning the reserve has dropped to a point where a major stressor can cascade into a crisis. Surgery, even a successful one, is one of the largest stressors a human body can face. Anesthesia alone suppresses the immune system for days. Lying still in a bed for hours creates the perfect environment for blood clots. Post-operative inflammation taxes the kidneys, and pain medications, often necessary, can cause confusion in older brains that last weeks. Something called post-operative cognitive dysfunction, or POCD. A landmark study in the journal Anesthesiology found that POCD affects up to 41% of patients over 65 after major surgery. Many of those patients and families were never warned. They thought something had gone permanently wrong with mom's memory. In many cases, it gradually resolved. In some cases, it didn't. This is the context. This is why age matters in surgical decisions. Not because older people can't have surgery. They absolutely can and do. It's because the math of risk and benefit shifts in ways that require a different, much more honest conversation. Let's talk about those 5 surgeries. Surgery number 1, unnecessary hysterectomy for non-cancerous conditions. Hysterectomy, the surgical removal of the uterus, is one of the most commonly performed major surgeries on women in the United States. About 600,000 are performed every year. And here is the uncomfortable truth. Research published in the American Journal of Obstetrics and Gynecology estimates that up to 70% of those hysterectomies may be medically unnecessary. 70%. Let that sit for a moment. The most common reasons women over 50 are recommended a hysterectomy are uterine fibroids, chronic pelvic pain, abnormal uterine bleeding, and uterine prolapse. Every single one of these conditions has multiple non-surgical treatment options that carry a fraction of the risk. Hormonal therapies, minimally invasive procedures like uterine fibroid embolization, where a catheter blocks blood supply to fibroids and causes them to shrink. Endometrial ablation, which addresses bleeding without removing the uterus. Pelvic floor physical therapy for prolapse. But here is what happens in too many doctors' offices. A woman comes in with symptoms, often postmenopausal, often with complicating health factors, and the path of least resistance is offered: a hysterectomy. It's a familiar procedure. The surgical team is comfortable with it, and the patient who trusts her doctor completely says yes. What doesn't get discussed thoroughly enough is what a hysterectomy does to a woman's body after 50. Beyond the surgical risks, blood clots, infection, damage to adjacent organs, there are long-term consequences. Women who undergo hysterectomy, particularly with removal of the ovaries, face significantly elevated risk of cardiovascular disease, osteoporosis, and sexual dysfunction. A 20-year study from Mayo Clinic found that women who had ovaries removed before 55 had a markedly higher risk of heart disease and stroke compared to those who didn't. If you have been told a hysterectomy is your best option for a non-cancerous condition, you are absolutely entitled to ask, what are all of my non-surgical options, and why are those not being recommended first? That question is not confrontational. It is your right as a patient. Surgery number 2, carotid endarterectomy in low-risk patients. Here's one that almost nobody talks about outside of vascular medicine circles, and it belongs on this list because it's being performed far more often than the evidence supports. Carotid endarterectomy is surgery on the carotid artery, the major blood vessel in your neck that supplies the brain. The procedure clears out plaque buildup to reduce stroke risk. For patients who have already had a stroke or a TIA, a transient ischemic attack, sometimes called a mini-stroke, in patients with severely blocked arteries, the surgery has genuine evidence behind it. It can save lives. But here's where it gets murky. Screening technology has gotten so good at detecting carotid plaque that doctors are now finding blockages in patients who have never had any symptoms whatsoever. And in far too many cases, those patients are being offered surgery based on imaging findings alone. A major trial called the CREST-2 study, published in the New England Journal of Medicine, found that for asymptomatic patients, people who have no stroke symptoms, intensive medical management with medications performed comparably to surgery in preventing strokes. Comparably. But the surgery carries its own risks: stroke, heart attack, and nerve damage during the procedure itself. The very thing the surgery is meant to prevent can be caused by the surgery. The risk of surgical stroke in carotid endarterectomy runs between 1 and 3% in experienced hands. That might sound low, but if you're a patient with no symptoms, being recommended surgery to reduce a future stroke risk that may be just as manageable with medication, you are being asked to accept a real immediate risk today to prevent a hypothetical risk tomorrow. The question you must ask your vascular surgeon if this is recommended to you: am I symptomatic or asymptomatic? If asymptomatic, what does the current evidence say about medication management versus surgery for someone with my specific profile? A surgeon who takes your question seriously and engages with it honestly is the surgeon worth listening to. If you're still watching and this helped, type 2 in the comments. And make sure to subscribe. We release powerful health content every day. Surgery number 3, robotic prostatectomy for low-grade prostate cancer. I told you number 3 would surprise people. Here it is. Prostate cancer is among the most common cancers diagnosed in men over 50. And when a man hears the word cancer, the psychological drive is powerful and completely understandable. Get it out, remove it, fight it. But here's what the data shows, and this is from the National Cancer Institute. The vast majority of prostate cancers diagnosed today are low-grade, what's called Gleason score 6. And low-grade prostate cancer is often described by oncologists themselves as a cancer you are far more likely to die with than die from. Active surveillance, regular monitoring without any surgical intervention, has been shown in multiple long-term studies to produce equivalent survival outcomes for low-grade prostate cancer compared to immediate surgery. The landmark PROTECT trial followed 1,643 men with localized prostate cancer for 10 years and found no significant difference in prostate cancer mortality between active surveillance, surgery, and radiation. And yet, radical prostatectomy, surgical removal of the prostate, increasingly done with robotic assistance, continues to be performed at very high rates for low-grade disease. Why? Partly because it is a definitive action in the face of frightening news. Partly because surgical systems represent enormous investment for hospitals, and partly because patients are not always presented with surveillance as a fully credible option. The consequences of prostatectomy matter deeply for quality of life. Urinary incontinence affects between 6 and 30% of men post-surgery depending on the study. Erectile dysfunction is one of the most significant outcomes. Rates vary widely, but are common and often long-lasting. These are not small side effects. These are life-altering changes. I am not telling any man to refuse treatment for prostate cancer. I am telling every man, if you receive a prostate cancer diagnosis, ask your urologist directly. What is my Gleason score? What does active surveillance look like for my risk profile? And what are the quality of life implications of each path? Those three questions alone could change the direction of your care. Before we continue, type 3 in the comments so I know you're here. And if you haven't subscribed yet, please do. Your support keeps us going. Surgery number 4. Multiple level spinal fusion for degenerative disc disease. Back pain is one of the most universal experiences of aging. If you're over 50 and your back has never protested, I'd like to meet you. The treatment path for chronic back pain has increasingly, over the past 2 decades, trended towards surgery, specifically multi-level spinal fusion. A procedure where 2 or more vertebrae are permanently joined together with hardware to eliminate movement at the painful joint. Here's what the evidence says, and this is important. For the most common form of chronic back pain in older adults, degenerative disc disease without neurological compromise, multi-level fusion has no better long-term outcomes than non-surgical management in multiple well-designed trials. No better. And the risks of the procedure in patients over 60 are substantial. A study published in Spine Journal found post-operative complication rates exceeding 40% in patients over 65 undergoing complex fusion. These were not minor complications. We're talking blood clots, wound infections, hardware failure, and adjacent segment disease where the vertebrae above and below the fusion begin breaking down because the rigid hardware has transferred load to them. But here's what truly sets this apart from other surgeries on this list. Fusion is permanent. You cannot unfuse a spine. Every other non-surgical option closes no doors. Physical therapy, epidural steroid injections, nerve block procedures, spinal cord stimulators, these can all be tried first. And if they don't work, surgery remains an option. But fusion locks you into an anatomy that cannot be reversed. I had a patient, retired electrician, 68 years old, 2 herniated discs in the lumbar spine. 2 different spine surgeons told him fusion was his best option. He asked me before agreeing. We referred him instead to a physiatrist, a physical medicine specialist, and started an aggressive 12-week course of targeted rehabilitation combined with a single epidural injection. At the end of that 12 weeks, he told me his pain had dropped from an 8 out of 10 to a 3. He never had surgery. He still doesn't. That was 6 years ago. Before agreeing to any spinal fusion, ask, has non-surgical management been genuinely and systematically tried first? Not one round of physical therapy, but a comprehensive, supervised program? If the answer is no, that is your answer. Surgery number 5. Aggressive surgical intervention in patients with advanced dementia. This is the most emotionally difficult surgery on the list, and it is the one that I believe causes the greatest unacknowledged suffering in our healthcare system right now. When a patient with moderate to advanced dementia develops a medical problem that could theoretically be treated surgically, a hip fracture, intestinal blockage, infected gallbladder, the family is faced with an agonizing decision, often in the middle of the night in a hospital corridor, often without adequate time or information. And the default in most hospital systems is to operate. Not because it is always the most compassionate choice, but because medicine is trained to intervene, families fear the guilt of doing nothing, and nobody has had the conversation about goals of care in advance. Here is what the evidence tells us about surgery in patients with advanced dementia. A major study in JAMA Surgery found that among elderly patients with dementia who underwent high-risk surgery, the majority spent their final months in institutional care settings, often in pain, often confused and unable to understand why they were where they were. Many could not participate in their own rehabilitation. Many developed the surgical complications we've discussed: infection, blood clots, delirium, without the cognitive ability to communicate their distress. The surgery technically achieved what it set out to do. The patient's quality of remaining life was frequently worse than if comfort-focused care had been chosen. I want to say this as clearly as I possibly can because I know families watching this may be facing exactly this situation. Choosing comfort care, palliative support, or hospice for a loved one with advanced dementia is not giving up. It is not a failure. In many cases, it is the most medically sound and loving decision available, and the data supports that. The action item here is not about surgery at all. It is about having the conversation with your family. Right now, while everyone is healthy, while everyone has time to think about what quality of life means to each of you, what matters, what you would and wouldn't want, and making sure those wishes are documented in an advance directive that travels with your medical records. That conversation had calmly around the kitchen table today may be the single most powerful thing you do for the people who love you. I want to share something before we get to the action steps. A man I'll call Victor came to my clinic at 74, former high school football coach. Built like a wall, but his knees were another story. Years of athletic wear had left him in significant pain. He'd already seen 2 orthopedic surgeons, both of whom recommended bilateral knee replacement, both knees at once. Victor's wife was beside him when he came in. She had already started researching rehabilitation facilities because they assumed surgery was inevitable. Victor himself said, "Doc, I just want to be able to walk my grandson to school. That's all I want." I went through his complete picture. He had type 2 diabetes that was poorly controlled. His hemoglobin A1C was 9.2, far above the 7.5 threshold most orthopedic programs use as a cutoff for elective joint replacement because uncontrolled diabetes dramatically increases infection risk and impairs wound healing. He had early-stage chronic kidney disease, and his cardiovascular stress test showed changes that warranted cardiology review before any major procedure. Victor was not a good surgical candidate. Not because of his age, because of his current physiological state. We did not send him for surgery. We sent him to an endocrinologist to get his diabetes under control. We enrolled him in a medically supervised weight loss program. We started him with a physical therapist who specializes in knee biomechanics. We added a single intra-articular injection to buy him some time. 8 months later, Victor's A1C was 7.1. He'd lost 22 pounds. His knee pain, he said, was maybe 40% better. He told me he'd walked his grandson to school 4 times that week, 6 months both. The surgery went smoothly. Recovery was textbook. He called me to say he'd just coached his grandson's flag football team from the sideline. Timing, preparation, information, those things mattered more than the surgery itself. Write these down. Screenshot this. Send it to someone you love. Question 1. What does my outcome look like if I choose not to have this surgery? This is the first question, and it is the most skipped. A surgeon's instinct is to present the surgical option. Your job is to make them paint the full picture. What does watchful waiting look like? What does medical management look like? Is there a meaningful clinical difference in outcomes at 1 year, 5 years, 10 years? A good surgeon will answer this honestly and completely. Question 2. What is my current frailty score or surgical risk assessment? Ask your surgeon if a formal frailty assessment has been done. The clinical frailty scale is one validated tool. The American College of Surgeons NSQIP Surgical Risk Calculator is another. These are not exotic requests. They are standard tools that help predict surgical risk. If your team looks at you blankly when you ask this, that itself is important information about how your surgical team is approaching your case. Question 3. What does a realistic recovery look like for my body specifically? Not the average patient, not the brochure. You, your kidney function, your heart, your current medications, your living situation, your support system. Ask your surgeon to walk you through, realistically, what the first week, the first month, and the first 6 months after surgery might look like for someone with your specific health profile. If they can't answer that specifically, they don't know your case well enough yet. Question 4. What is your personal complication rate for this procedure in patients over 65? Surgeons track outcomes. They have data. A confident, transparent surgeon will tell you their numbers without hesitation. If the question makes them uncomfortable, or if they deflect to national averages, you are not getting the full picture. Your right to this information is not negotiable. It is your body. What's actually possible right now? I want to leave you with something genuinely optimistic, because this is not a video about fear. Fear is the enemy of good decision-making. Information is the antidote to fear. Medicine in 2024 has never been more sophisticated in its non-surgical options. biologics, and targeted therapies for inflammatory joint disease, focused ultrasound for essential tremor that previously required brain surgery, catheter-based cardiac procedures replacing open chest operations, nerve block techniques for chronic pain that provide relief without a single incision. And beyond all of that, the proven, undervalued power of prehabilitation. Getting your body into the best possible shape before an elective procedure is real and documented. Patients who go through structured prehabilitation programs show dramatically lower complication rates, shorter hospital stays, and better functional outcomes post-surgery. Some hospitals now require it before scheduling certain operations for older adults. And that is exactly the right instinct. Body given the right tools and the right time wants to heal. Your job is not to surrender your health decisions to the system. Your job is to show up informed, to ask the hard questions, to request the alternatives, and to give yourself every possible advantage before agreeing to anything. 5 surgeries that carry serious, underexplained risks for people over 50. First, unnecessary hysterectomy for non-cancerous conditions where multiple effective alternatives exist and are chronically underoffered. Second, carotid endarterectomy in asymptomatic patients where current evidence supports that intensive medication management performs comparably without surgical risk. Third, robotic prostatectomy for low-grade prostate cancer, where active surveillance has equivalent survival outcomes and none of the life-altering side effects. Fourth, multi-level spinal fusion for degenerative disc disease without neurological compromise, where non-surgical programs consistently match surgical outcomes without permanent anatomical changes. Fifth, aggressive surgical intervention in patients with advanced dementia, where the most compassionate and often most medically sound path may be comfort-focused care and honest goals of care conversations held long before any crisis occurs. None of this means surgery is the enemy. Surgery is extraordinary. I have watched it give people their lives back. The message is simpler than that. You are not a passive recipient of medical decisions. You are the most important member of your own healthcare team. A surgical recommendation is the beginning of a conversation, not the end of one. Ask the hard questions. Demand specific answers. Get a second opinion. Optimize your body before any elective procedure. Document your wishes for emergencies, and share this with anyone over 50 who is facing a surgical recommendation. Because the most powerful tool in medicine is an informed patient walking into that conversation with clear eyes and the right questions. What question do you wish you had asked before a surgery or before a loved one's surgery? Tell me in the comments. I read every single one, and your experience might be exactly what someone else needs to hear today. If this video gave you something useful, share it. One share might change the most important decision someone makes this year. Take care of yourselves. Stay curious. Keep advocating. You deserve a medical team that treats you as a partner, not a patient number. And the moment you start asking better questions is the moment that partnership begins. Everything shared in this video is general medical information based on published clinical research. Every individual's health situation is unique. Always have a full, direct, and unhurried conversation with your own physician or specialist before making any decisions about surgery or treatment. Your doctor knows your history, your body, and your full picture. That conversation, informed and honest, is where great medicine begins.